Radiosurgery, or more commonly referred to electrosurgery, is one of the most versatile instruments we have in the dental office. With its variety of waveforms and various cutting tips, we can rapidly remove soft tissue with varying amounts of hemostasis. This rapid tissue removal affords us a clear field of visibility and in turn reduces stress of both the doctor and patient. The fully rectified waveform is used to remove soft tissue while establishing hemostasis. This is advantageous when exposing subgingival decay and facilitates bonding procedures. After tooth preparation, the partially rectified waveform can be used to establish coagulation, allowing us to work in a bloodless field. A bendable pencil point shape number 117 electrode is helpful in controlling bleeding in small interproximal areas. Radiosurgery increases bond strength by preventing blood contamination of the etched tooth structure. It facilitates the placement of a composite by controlling bleeding with increased visibility for the doctor. Radiosurgery, with its micro-smooth, pressureless cut, allows for a stronger, more aesthetic restoration while reducing stress and chair time. This bloodless field can lead to a stress-free placement of a composite restoration. A bendable U-shape loop number 114 electrode is used with a fully rectified waveform to remove the soft tissue and expose any subgingival decay. Irrigation of the surgical site is used to remove any debris. The bendable pencil point number 117 electrode can then be used with a partially rectified waveform to establish coagulation of the soft tissue. The electrode tip can be contoured to help establish better access to the surgical site. Radiosurgery is used to expose subgingival decay or areas of cervical erosion. We can use radiosurgery to help establish a more aesthetic and durable bonded restoration. The fully rectified waveform has the advantage of producing cutting with concurrent hemostasis. When an incision is made, coagulation occurs on either side of the electrode tip. Here we are using a disposable straight wire vari-tip electrode with a fully rectified waveform to fully expose the area to be bonded. This procedure is performed prior to preparing the tooth to help establish a better field of visibility and to fully establish coagulation prior to placement of our bonded restoration. The surgical site is constantly irrigated and cleansed with the air-water syringe to facilitate visibility. Any loose tissue tabs are removed from the surgical site and the electrode tip as well. A high-speed evacuation tip is placed in close proximity to the surgical site to remove any tissue tabs and odor as well. The vacuum created from the suction tip helps to keep the tissue cool and free of debris.
The tooth is prepared as needed, and then any loose tissue tabs are removed and the surgical area redefined prior to use of an etch and resin. In this case, we're using 3M's L-Pop as a one-step etch and resin placement. A flowable composite can be comfortably used without having contamination of blood into the prepared site. A 113 pencil-shaped electrode can be used with a partially rectified coagulating waveform to fully establish any additional coagulation that might be needed. The partially rectified waveform is an intermittent flow of high-frequency current, which is excellent in producing hemostasis of the soft tissue. The tooth can then be finished and polished, producing a durable and more aesthetic restoration. In this area, I am using the Vari-Tip straight wire electrode with the fully rectified waveform. The Vari-Tip electrode offers the advantage of a variable length wire that can help establish a more predictable incision. The sulcus can be probed and the variable length cutting wire can be adjusted. We can therefore have a more predictable surgical incision. As we move from tooth to tooth, our visibility is enhanced due to the absence of any blood, making the incision quick and predictable. The teeth are prepared and the bonding resin placed without contamination of blood to the area. Here you can see some lower bicuspids with advanced cervical erosion. The fully rectified waveform is being used with the Vari-Tip electrode to expose the erosion of the tooth. Notice the lack of bleeding in this area and realize the advantage of using radiosurgery around all our bonded restorations. Any areas of oozing can be easily controlled using the 113F pencil-shaped electrode with a partially rectified coagulating waveform. The procedure of exposing any cervical erosion or subgingival decay is explained to the patient as having a gingivectomy or gingivoplasty being performed. I usually explain that the gum tissue was inflamed or thickened in the area and that removal of the tissue helps to establish a more aesthetic and healthy result. The patient is cautioned not to eat any spicy foods for several days while the tissue heals. The maxillary central incisors are being prepared for Procera porcelain crowns. After preparation is complete, a Varitip electrode is used with a fully rectified filtered waveform to widen the sulcus and create a trough. The fully rectified filtered waveform is a continuous, non-pulsating flow of current which provides a micro-smooth incision. Even with its decreased coagulating ability, the fully rectified filtered waveform establishes a high degree of hemostasis when used around healthy gingival tissue. The electrode is placed parallel to the tooth and is used to widen the sulcus without removing any tissue height. A 113F pencil-shaped electrode is used with a partially rectified waveform to fully establish coagulation. This coagulation can be further enhanced if needed with the aid of retraction cord and/or a hemostat. The retraction cord is removed with no evidence of bleeding. And the 3M imprint impression material is injected into the dry sulcus to take an impression, not compromised by blood, and therefore producing an impression without any voids and with accurate marginal integrity. A press form temporary stent was prepared on a study model of the patient and is then filled with Elman Templa Shade 61 acrylic. The stent is placed on the blood-free prepared teeth and allowed to set, producing a more aesthetic restoration. Once removed from the mouth, you can see that blood did not contaminate our temporary bridge, and placement of this bridge resulted in a happy patient.
We can use radiosurgery to facilitate a crown preparation. The tooth is prepared with the use of a high-speed diamond. A bevel finish line is then placed. A fully rectified filtered waveform is used in the anterior region to widen the sulcus and fully expose the margin of the preparation. A bendable vari-tip straight wire number 118 electrode with its delicate size and cut allows us to create a trough. The trough procedure is performed in several separate incisions. We can remove tissue from the mesial, facial, distal, and lingual surfaces to fully expose the margin of our preparation. Several delicate incisions are performed, giving a controlled widening of the sulcus and allowing us adequate visibility of our finish line. One of the main advantages of radiosurgery is the amount of hemostasis obtained, giving us excellent visibility of the preparation, as well as facilitating the impression-taking procedure. Retraction cord may be used in those situations requiring additional hemostasis or where the doctor feels more comfortable using it. In those situations where radiosurgery has been performed, the cord's placement is much easier and with a minimal amount of bleeding. Once hemostasis is achieved, the cord is removed and the impression material can be injected around a bloodless preparation, thus eliminating the chance of any voids in our impression. Upon removal of the impression, we are able to see a clean, clear impression of our preparation, which allows for the successful construction of a crown by the laboratory. The temporary crown can be easily cemented thanks to the lack of bleeding due to the use of the radiosurgery instrument, making this a stress-free crown preparation. On this maxillary lateral incisor that was previously prepared, the temporary crown is removed. A bendable vari-tip number 118 electrode is contoured to allow easy access and enhanced visibility and widening of the sulcus. A fully rectified waveform is used because of its ability to delicately remove the soft tissue in the anterior region where the tissue is thin and frail. The trough that is created will fully expose the finish line of the prepared tooth and will facilitate the impression taking. The sulcular tissue is removed in several incisions rather than one continuous uncontrolled incision. One of the advantages of the vari-tip electrode is that we can control the depth of our cutting tip, and after probing can adjust the tip length to prevent accidental cutting of the epithelial attachment. The tissue can be irrigated while doing radiosurgery. The irrigation removes any debris and odor and gives us a clear field of visibility. The central suction is kept in close proximity to the surgical site to facilitate debris and odor removal, and at the same time to create a vacuum over the tissue for cooling purposes. We can notice with radiosurgery that there is very minimal bleeding occurring. This pressureless incision, in conjunction with the lack of bleeding, aids in total patient comfort and in turn creates a stress-free environment for the dentist. Once the sulcular tissue is removed, hemostasis can be fully obtained using the partially rectified waveform and a bendable pencil point number 113F electrode tip. The tip is lightly placed around the tissue to establish coagulation. Any bleeding that is occurring is irrigated first and then dried prior to placing the electrode on the tissue. The impression can be taken without the use of retraction cord. We have established an adequate impression with precise margins with no or minimal bleeding occurring. Even when the temporary crown is replaced, we see that there is no bleeding.
A mandibular second bicuspid that had previous endodontic treatment is being prepared for a porcelain fused to gold crown and cast post. A slow-speed engine reamer is used to remove the gutta percha from the prepared tooth. After completion of the preparation, a vari-tip electrode is used with a fully rectified waveform to widen the sulcus and create a trough. The fully rectified waveform is used in this instance due to its enhanced coagulating ability. A 113F pencil-shaped electrode is used with the partially rectified waveform to fully establish coagulation. Retraction cord is easily placed within the widened sulcus. 3M imprint impression material is used to take the impression. The accuracy of the impression is due in part to the use of radiosurgery, which fully exposed the margin of the preparation as well as minimized any bleeding.
A labial frenum can create a muscle pull on the mandibular incisors. If left untreated, This situation could lead to an advanced periodontal condition and possible loss of the tooth. A fully rectified filtered waveform is used to smoothly incise the frenum. This waveform is indicated due to the proximity of the underlying osseous structures. The bendable vari-tip number 118 electrode is used to perform the microsmooth incisions needed to fully remove the frenum. These incisions can be made with minimal bleeding and increased operator visibility due to the advantage of radiosurgery. Several precise incisions are made to ensure that the muscular tissue is fully removed. The fulgurating current, with its electrode placed in close proximity to the tissue, allows a spark to jump across and destroy any muscular tissue while creating hemostasis at the same time. Once hemostasis is established, sutures can be placed. Irrigation of Peridex or chlorhexidine is used if desired. Several coats of tincture of murrin benzoin are applied, followed by the placement of a periodontal pack if indicated, to assure total patient comfort. Here we see the postoperative healing. The soft tissue covering a partially erupted tooth can become inflamed or swollen, creating a pericarditis. The inflammation of the tissue is usually due to either trauma from the opposing teeth or inflammation caused by bacteria and debris being trapped below the tissue. An operculectomy is the surgical removal of this tissue and can be rapidly and effectively performed with radiosurgery. The waveform of choice would be the fully rectified waveform. This waveform gives us cutting with hemostasis and is strictly used for the soft tissue removal when we are not in close proximity to the bone. After administration of block anesthesia, a bendable U-shaped loop electrode number 114 is used to remove the operculum and expose the erupting tooth structure. The advantage of a bendable electrode is that it can be contoured to facilitate the access needed to remove the operculum. The tissue is dissected out in a fashion similar to the procedure used to widen the sulcus and create a trough during a crown preparation. With the aid of radiosurgery, we have excellent visibility as well as patient comfort due to the minimal amount of bleeding and its pressureless incisions. The central suction is placed in close proximity to the surgical site to remove any blood, tissue debris, and odor, and to ensure maximum patient comfort. The vacuum created by the central suction also creates a cooling effect to the underlying tissue. A partially rectified waveform and a bendable pencil point number 117 electrode is used to control any areas of persistent bleeding. The area is dried of blood with the air-water syringe, and the electrode is lightly touched through the tissue to establish coagulation. A postoperative dressing of tincture of murrin benzoin is liberally being applied in several layers, with air drying between each layer. The murrin benzoin will act as a post-operative dressing that will not interfere with the patient's eating or speaking functions. A chlorhexidine oral rinse may be further prescribed for patient comfort.
A patient reported with bilateral inflamed operculum over the mandibular third molars. A number 128 loop electrode was used with a fully rectified waveform to excise the operculum. The angle of the loop electrode was bent slightly to contour to the area of the surgical site. The fully rectified waveform was used for its combined cutting and coagulating ability. After the tissue was excised, the surgical site was liberally irrigated with a chlorhexidine solution. A squeezette was used to place a dressing of tincture of murrin benzoin on the surgical sites with air drying between layers of solution.
The use of diphenylhydantoin sodium, or dilantin, for seizure control results in gingival hyperplasia in almost half of all epileptic patients treated with this drug. This hyperplasia is seen clinically as a fibrous overgrowth of gingival tissue which appears light pink in color and exhibits no or minimal bleeding on probing. Surgical removal of this tissue can be accomplished in a rapid, pressureless fashion with only a minimal amount of bleeding when radiosurgery is used. A fully rectified waveform is used to remove the tissue due to the fact that the tissue is hyperplastic and in no way in close proximity to the underlying bone. The advantage of using the fully rectified waveform is that cutting with concurrent hemostasis can be accomplished. A bendable vari-tip number 118 electrode is used to remove the tissue and fully expose the coronal portion of the tooth. The vari-tip electrode is advantageous since its length can be varied to correspond to the different areas of hyperplasia, allowing for the easy removal of the tissue. The air-water syringe can be used to facilitate tissue and blood removal, increasing the doctor's visibility as well as the patient's comfort. The occasional irrigation of the surgical site allows us to keep the tissue cool. We notice that there is only a minimal amount of bleeding occurring as the tissue is being removed in comparison to removing this tissue with a scalpel. A large bendable loop U-shaped number 128 electrode is used to facilitate the gingivoplasty procedure. The tissue can be planed or contoured by using the loop electrode. The loop is guided in a pressureless manner with only minimal contact with the tissue. A smaller bendable U-shaped number 123 loop electrode can be used to define our gingivoplasty and to remove or recontour any small areas of interproximal tissue. A bendable pencil point number 117 electrode tip is used with a partially rectified waveform to establish hemostasis. This waveform is used for coagulation only and is never used to incise tissue. The surgical site is irrigated and lightly dried with the air syringe. The electrode tip only lightly contacts the soft tissue in order to establish coagulation. A thinner pencil point, number 113F electrode, can be used in small interproximal areas to further establish coagulation. The lingual tissue is often difficult to visualize. Radiosurgery is an excellent instrument that can be used to facilitate the tissue removal and contouring. The fully rectified waveform, with its ability to delicately incise tissue and establish hemostasis, can allow us to remove the tissue with greater ease and increased visibility. The bendable electrodes are extremely useful when removing this tissue. The ability to bend these electrodes increases operator access and minimizes chair time needed to perform this procedure. The surgical suction can be a useful tool when placed in close proximity to the surgical site. The tissue tabs are easily removed, increasing patient comfort. The bendable U-shape number 108 electrode is used to remove interproximal tissue. This loop affords better access to the interproximal areas in comparison to the thin, vari-tip electrode. The pencil point number 113F electrode can be used with a partially rectified or coagulating waveform to reestablish hemostasis and increase the field of visibility throughout the surgical procedure. A larger, bendable number 117 pencil point electrode can be used in areas of persistent bleeding, often requiring several applications with a partially rectified waveform. Several coats of tincture of myrrh benzoin are liberally applied to the surgical site. The tincture of myrrh benzoin is air dried between each layer. A periodontal pack is placed for increased patient comfort and healing. A pulpotomy, or the removal of the coronal portion of the pulpal tissue, can be effectively accomplished with the aid of radiosurgery. The pulpal tissue of a deciduous tooth is exposed using a high-speed handpiece. A fully rectified waveform is selected. This waveform produces cutting with hemostasis. A bendable U-shaped number 114 electrode is best suited for removal of the coronal portion of the pulpal tissue. A partially rectified waveform with a bendable pencil point number 113F electrode is then used to cauterize any pulpal tissue remnants. A larger pencil point number 117 electrode is used to establish hemostasis from interproximal tissue that is oozing. A ZOE or PT2-based material can then be placed, followed by an amalgam or crown restoration, effectively making this a one-appointment pulpotomy procedure.
A patient reported with a mandibular molar that had undergone endodontic therapy. The gingival tissue had overgrown the tooth, and radiosurgery was used to expose the tooth. A disposable 108 U-shaped electrode was used with a fully rectified waveform to expose the remaining tooth structure. The disposable electrodes are identified by their white-colored protective sleeve. The fully rectified waveform was used for its combined cutting and coagulating ability. A 113F pencil-shaped electrode was used with the partially rectified coagulating waveform. Due to areas of extensive hyperemic tissue, a thicker autoclavable number 117 pencil-shaped electrode was used to enhance the coagulation. The autoclavable electrodes are identified by their blue protective sleeve. Upon hemostasis and a thorough reevaluation of the remaining tooth structure, it was decided that an extraction of the tooth was indicated. After extraction, an ACE number 128 loop electrode was used with a fully rectified filtered waveform to curette the granulation tissue in the extraction socket. The combination of the ACE electrode and the fully rectified filtered waveform were used due to the proximity of the underlying bone in the socket. A patient reported with what appeared to be an irritation fibroma on the lower left lip. The lesion was raised and firm. A biopsy was performed to remove the lesion. A disposable number 128 loop electrode was used with a fully rectified filtered waveform to remove the specimen, to allow the pathologist a clear field of visibility. The specimen is rapidly removed with minimal bleeding. Several 4-row continuous sutures were placed. A pathology report shows the ease of confirming the initial diagnosis by the pathologist.